Let's discuss about scorpion sting. Note that it is sting, not bite. Scorpion sting in children is an acute, life-threatening rural medical emergency. Scorpion venom is more potent than the snake venom. Severe excruciating pain radiating along corresponding dermatomes and life-threatening systemic effects may be noted in the scorpion sting. Clinically important species are red scorpion and black rock, Indian red scorpion and Indian black rock scorpion. The red scorpion is called as a Mesobuthus tumulus. Mesobuthus tumulus. Mesobuthus tumulus. You can remember it as a MTR. Mesobuthus tumulus is a red scorpion. One more time. Mesobuthus tumulus. Say with me. Mesobuthus tumulus is red scorpion, MTR. Okay. The black rock scorpion is a Palaemnius swammerdami. Palaemnius swammerdami. Palaemnius swammerdami. Palaemnius swammerdami. Palaemnius swammerdami. Palaemnius swammerdami. That is Indian black rock scorpion. So one more time, Mesobuthus tumulus is red, Palaemnius swammerdami is black. Predisposing factors are warm, dry regions in the night time, summer months, typical Rajasthan vibes at night. You can remember it as Rajasthan desert kind of scene at night where scorpions are there. That is the predisposing factor. Scorpion use their stings only when roughly handled. It can control its ejaculation. Coming to the pathophysiology of scorpion venom, it is a kind of a cocktail of chemicals including mucopolysaccharide, hyaluronidase, phospholipase, acetylcholine esterase, serotonin, histamine, protease inhibitors, histamine releasers and neurotoxins. So these all kind of chemicals are released in the scorpion venom. So that's why it is called as a cocktail of chemicals. They stimulate alpha receptor. These all will stimulate the alpha receptors, causing the hypertension, tachycardia, myocardial dysfunction, pulmonary edema, cool extremities, can also lead to DICs, hemorrhage, necrosis of liver. So many causes. Neurotoxins acts by inactivating the sodium channels, leading on to autonomic dysfunction. It inactivates the sodium channels. Sodium channels are there. No, this is cell. This is sodium channel where sodium will come in and potassium will go out in the resting potential. But in the active phase, sodium will go out and potassium will be coming in. Sodium will go out, potassium will be coming in. Nokia, you remember this, no? Nokia, sodium out, potassium in. So sodium out, potassium in, this will inhibit the sodium channels, that will lead to building up of the action potential, that will lead to maximum activation leading to the autonomic dysfunction. Hemodynamic changes are secondary to transient cholinergic effects, secondary prolonged adrenergic effects, and are severe inflammatory response syndrome. Serotonin is the major factor for the pain. So here you can see the pathophysiology where a scorpion sting lead to the venom release, sodium channel activation, because of the sodium channel activation leading to the autonomic storm, where parasympathetic stimulation is there as well as sympathetic stimulation is there. Because of the sympathetic stimulation, there is endothelin secretion, vasoconstriction and angiotensin stimulation, hypertension and coronary spasm. This will lead to the hypokinetic pulmonary edema, tachycardia and hypotension shock. Sympathetic stimulation, catecholamine release will cause the myocardial injury leading to the hypotension, shock, tachycardia. Coming to the P substance and serotonin, which leads to the local pain. Kallikrein will lead to the bradykinin increase, causing the vasodilation, which lead to the non-cardiac pulmonary edema, hypotension and pancreatitis. This is the pathophysiology of scorpion sting. This is depicted in this graphical representation, where there is a scorpion sting will lead to the cocktail of chemicals: hyaluronidase, serotonin for pain and surge, neurotoxin channel stabilizer, leading to the sodium channel overdrive. That is, neurotoxins prevent the sodium channel inactivation, causing the persistent depolarization of massive neurotransmitters. When sodium is keep on building up in the cell, leading to the increased action potential, which will in turn lead to the activation of these neurotransmitters. The neurotransmitter will keep on giving signals, which will lead to the overactivation of these neurotransmitters. It will keep on releasing the neurotransmitters that will lead to the autonomic storm and as well as prolonged sympathetic storm. Autonomic storm is a transient, that means for some times it will be there, which is like a tidal wave. You can remember it as a tidal wave, it will come and go, but after that prolonged sympathetic storm is seen. In the autonomic storm, there can be vomiting, profuse sweating, hypersalivation, bradykinia leading to the hypotension. After some time, there is prolonged sympathetic storm is there, where massive catecholamine release leads to the crisis of hypertension, tachycardia, cold extremities, pulmonary edema, which in turn is complications of myocardial and pulmonary crisis. High catecholamine causes some myocardial toxicity and hypokinetic heart failure, leading to the pulmonary edema. So this is about the pathophysiology. Coming to the clinical features. So clinical features are like autonomic storm, pain in the earliest symptom. Pain is the earliest symptom. There can be irritability, incessant cry, minimal or no skin reaction. Pain severity progresses during first 5 hours. In 5 hours from the bite, the pain severity progresses. Okay, after that in 24 to 48 hours it starts subsiding. Older children may also complain the paresthesia near the sting site, especially during the recovery. During the recovery, there is a paresthesia. Severe shock-like pain is there. Tap test is positive, where tapping over the sting site may be present. Severe shock-like pain is present tapping over the sting site, because if you keep on tapping over the sting site, there are these chemicals released because of the nerve irritability. There are lot of catecholamines will be produced that will lead to the severe shock like radiating pain. Autonomic storm is there, transient parasympathetic activity by prolonged followed by the prolonged sympathetic stimulation. Features of parasympathetic stimulation as we have seen here. Parasympathetic stimulation, vomiting, profuse sweating, hypersalivation, bradycardia and hypotension. The clinical features of sympathetic storm is hypertension, tachycardia, cold extremities, pulmonary edema, myocardial toxicity, hypokinetic heart failure, pulmonary edema. So all of these are sympathetic. Here you can see the sympathetic are shock, pulmonary edema, myocardial dysfunction, tachycardia, hypertension and cold extremities. In parasympathetic stimulation, vomiting, profuse sweating, hypersalivation, bradycardia, ventricular premature contractibility, priapism and hypotension. Many patients show hypertension and or left ventricular dysfunction. Hypertension as well as left ventricular dysfunction at the presentation, and progression of symptoms rapid within the maximum severity within the 5 hours. Maximum severity is seen within 5 hours. So whenever this scorpion sting will occur, there are at the site, suppose this is hand and here one scorpion bite is there. So based on this bite, which kind of bite is it, how severe it is, there is a grading, clinical grading of scorpion sting severity. So that is divided into grade 1, grade 2, grade 3, grade 4. Grade 1, local pain and paresthesia at the sting size without inflammation. Grade 2 is remote pain and paresthesia radiating proximally up the affected limb. Coming to the grade 3, cranial nerve dysfunction can be there or neuromuscular dysfunction can be there. Coming to the grade 4, cranial nerve dysfunction as well as neuromuscular dysfunction will be there. Both will be there. So in grade 3 and grade 4, treatment is scorpion specific F antibody administration. So here in the grading severity it is seen grade 1, grade 2, grade 3, grade 4. Grade 1 is localized reaction, grade 2 is a regional spread, grade 3 is neurological dysfunction which is targeted, and grade 4 is a systemic failure. In grade 1, the pain and paresthesia limited to the strictly to the site of the sting. Suppose this is the site of a sting, only in this area paresthesia and pain will be there. Suppose it is bitten here, in the grade 2, here also it's there, and in whole of the body, in the remote site, there is paresthesia and radiating pain is seen generalized. That is grade 2. And grade 3, there is either cranial nerve dysfunction or somatic skeletal neuromuscular dysfunction. Cranial nerve dysfunctions like blurred vision, roving of eye movement, slurred speech, tongue fasciculations, hypersalivation. Tongue fasciculation is like just like a dog, dog, how the dog is putting its tongue always out and it is coming out and in of the inside the mouth. So that is called as a tongue fasciculation, as well as hypersalivation. Whenever you see the dog, there is fasciculations and there is a dribbling of these saliva, that is hypersalivation. Since dog cannot speak, so slurred speech, roving of eye movement, the dog can only rotate its eye, blurred vision. So these cranial nerve functions, cranial nerve dysfunctions, you can remember by the imagining the dog. Okay. Somatic skeletal dysfunctions are restlessness, muscle fasciculations, alternating opisthotonus and emprosthotonus. Coming to the grade 4, where both cranial nerve and somatic skeletal dysfunctions are seen. So this is the grading, clinical grading of scorpion sting. Coming to the investigation, since there is pulmonary edema as a complication, so that why you will do chest x-ray. Since there is myocarditis, you will do ECG, where you will see the peaked T waves in a V2 to V6 ST segment elevation in the lead 1 and AVL. You just remember peaked T waves, ST segment elevation, increased QR interval, and LVH, left ventricular hypertrophy by voltage criteria, low voltage complexes indicating the poor prognosis. So suppose this is a P wave, this is Q wave, and QRS, T wave, peaked T waves and ST segment elevation you can see. Okay, increased QR duration and left ventricular hypertrophy and ST segment elevation, peaked T waves. So this is the ECG, how it looks in the myocarditis. Echocardiography, to look for the left ventricular systolic dysfunction, left ventricular dilation with regional wall motion abnormalities. So investigations are X-ray, ECG and echocardiography. Coming to the management, for pain you will give paracetamol, ibuprofen, wound cleaning, tetanus prophylaxis, as well as monitoring of the patient for respiratory distress, hyperthermia, rhabdomyolysis, multi-organ dysfunction. Then you will attach for IV line and give the fluid balance because of the vomiting and sweating, salivation. Because of this parasympathetic activity, there is a lot of fluid loss, so that's why you will put the fluid. And then since there is a lot of fluid, so oral secretion will be there, so suctioning should be done. Then midazolam for sedation because of the muscle spasticity. IV fentanyl as a pain relief. Prazosin, if there is hypertension and vasoconstriction, then only this prazosin will work. Okay, prazosin indicated in all cases with the autonomic storm. Here in autonomic storm, in there is autonomic storm is there, no, in this case only prazosin will work. Here in this section the prazosin will work, not here, never, because in hypotension you cannot give the prazosin. Here only you can give prazosin. How much you can give prazosin? 30 microgram per kg per dose. Okay, you can give prazosin. So prazosin, peripheral circulatory failure, competitive post-synaptic alpha adrenoreceptor antagonist, it is reduces the preload afterload, useful in the management of vasoconstriction, hypertension associated with the alpha receptor stimulation, as we have discussed here. See, there are autonomic dysfunctions like because of the sodium channel overdrive. First there is parasympathetic surge, then there is a sympathetic storm. In this sympathetic storm we will give prazosin 30 microgram per kg per dose. Hypotension, it is avoided. 3 to 6 hours you can give, within 3 to 6 hours, still the extremities are warm. Pulmonary edema, for that you will give sodium nitroprusside infusion or ACE inhibitor. Inotropes like dobutamine 15 mg per kg per minute, sodium nitroprusside 0.3 to 5 mg per kg per minute, scorpion antivenom and scorpion specific F antibody. So patient can be discharged after observation for 6 hours if there is no progression of symptoms. So here you can see the clinical management from scorpion bite. When the scorpion bite occurs, there are so many cocktail chemicals are released, leading to the vomiting, bradycardia, vomiting and bradycardia, which is a parasympathetic symptom. It is a transient. First the parasympathetic system will activate, leading to the vomiting and bradycardia, hypersalivation, all those. After that the sympathetic will activate, leading to the tachycardia, hypertension and pulmonary edema. Persistent cry is there, priapium is there, cold extremities are there, profuse sweating is there. So these will be useful in identifying the severity of this scorpion bite. Suppose there is sympathetic symptoms are there, all the symptoms are there. Now you have to grade as a clinician. Grade 1 is a local pain, it is local pain and paresthesia. Grade 2 is a remote pain and paresthesia, proximal from the site. And grade 3 is cranial nerve dysfunction or neuromuscular dysfunction. Grade 4 is a combined both cranial nerve and systemic skeletal neuromuscular dysfunction. After that you will go for the management. Main management is prazosin alpha 1 antagonist 30 microgram per kg per dose, indicated in autonomic storm and peripheral circulatory failure. So this is prazosin primary treatment. Then scorpion specific F antibody antivenom administered as early as possible for the patient presenting for grade 3 and grade 4 neurotoxicity. Now supportive care essentials are midazolam for sedation for muscle spasticity, IV fentanyl for pain, maintenance of the strict fluid balance to manage the pulmonary edema. So all these are the management. Coming to the revision, fastly we will just revise. Okay, so scorpion sting, acute life threatening rural medical emergency. Red is there, black is there. Red is called as a Mesobucus tumulus, black is called as a Palampneus swamardhani. Then predisposing factors, imagine the Rajasthan. And then severe excruciating pain is there. Pathophysiology, how is the pathophysiology means scorpion bite is there because of the venom, sodium channel activation, overactivation lead to the autonomic storm. There is parasympathetic and followed by the sympathetic is there, vomiting, profuse sweating, hypersalivation, bradycardia, hypotension. Then coming to the sympathetic storm, hypertension, tachycardia, cold extremities, pulmonary edema leading to myocarditis. Then after that uh, kallikrein-kinin leading to the bradykinin increase, which is a vasodilator leading to the pancreatitis, hypotension and non-cardiac pulmonary edema. P substance and serotonin causes the local pain. This is the pathophysiology. Coming to the severity grading, you have seen grade 1, grade 2, grade 3, grade 4. Grade 1 is local, grade 2 is remote, grade 3 is cranial nerve or somatic skeletal dysfunction, grade 4 is plus, that is both cranial nerve and somatic skeletal dysfunction. Coming to the management, autonomic storm is there, parasympathetic followed by sympathetic leading to the grading as we have discussed. Main is a prazosin, next is a scorpion specific F antibody. For pain relief, paracetamol and all supportive treatments. For supportive care, we will give midazolam for sedation, IV fentanyl for pain, maintenance of the strict fluid balance. So this is about the scorpion bite.